Well, thanks so much to everybody for joining us today for the CTN webinar series entitled In the Weeds, Assessing Neurocognitive, Brain Imaging, and Substance Use Measures in Emerging Adults. My name is Staci Gruber, and I'm the Director of the Cognitive and Clinical Neuroimaging Core at McLean Hospital and an Associate Professor of Psychiatry at Harvard Medical School. I am also fortunate enough to have been funded generously by NIDA for many years at this point, and I thought it would be most helpful in terms of presenting a methodologic approach to better assessment measures in this particular population by actually putting it against a backdrop of actual research. So the research that I'll present during the webinar is actually research that was funded by NIDA. So today, in terms of learning objectives, at the conclusion of this presentation, I have no doubt that all of the participants should and will be able to define some of the difficulties commonly associated with assessing substance use in adolescent and emerging adult populations. You'll be able to recognize the importance of a clear study design with well-articulated substance use assessment measures administered in a reliable, consistent, and comprehensive manner. You'll be able to understand how to modify common tools for substance use assessment for a range of substances, for example, using things like the timeline followback, or TLFB. And you'll be able to identify a number of ways to improve the quality of data or information offered by adolescent and emerging adult subjects, which can often be challenging. So at this point, this actually brings up our very first poll question. We'll have several poll questions throughout this presentation, which are really designed to get you to give me a little bit of information in terms of what you most commonly encounter. So for those of you who are already tuned in, how often do you verbally ask about last use of substances in your subjects? All of the time, most of the time, some of the time, or never? So if you could go ahead and key in your response, that would be great. I have no Jeopardy type music, but just imagine it playing in the background. Bum, 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 but we'll give everybody a few seconds. Okay, we've closed the polls. So 61.5% of you say you ask subjects all of the time about their last use of substances, which is great. Another almost 31% of you ask most of the time, and just a few of you are never. I recommend for those of you who say never, it's actually really important to verbally ask subjects about their last use of substances, because very often between the time that you've screened your subjects and the time they actually appear, things have changed. So it was important to really ask these questions. One more poll question, and then we'll get into the actual meat of this webinar. For, again, those of you, you can answer again on the screen. Have you had difficulty quantifying subjects' substance use? Yes or no? Go ahead and use the screen to post your answer. Have you had difficulty quantifying subjects' substance use? And it looks like almost 82% of you have had difficulty quantifying subject substance use. And I am not surprised. It's a really common problem. About 20% of you say no, which is also very encouraging. And perhaps in our Q&A section we can talk about ways to improve the quality of quantifying subjects' responses. But let's go ahead and get into the meat of this. So again, as I mentioned, I think the best way to talk about methods for assessing substance use amongst this population is really to do it against the backdrop of actual research. So for the better part of a little more than 20 years, I've been studying, among other things, the effect of recreational marijuana on various measures of brain structure, function, cognitive performance, clinical state, you name it. And unless you're living on Mars, it really does seem like marijuana is everywhere. I love this little picture. From Snoop Dogg to Kristen Stewart, and every celebrity seems like in between. We spend a lot of time talking about marijuana these days, and that's not surprising given the fact that 25 states plus DC now have legalized medical marijuana, another 18 have partial medical marijuana laws, and 4 states plus DC have legalized recreational marijuana, with a number of other states currently pending legislation. Important to our topic today, teens' perception of risk and harm associated with marijuana use continues to drop. It is now at a historic low. It was a statistically significant drop between 2014 and 2015. In fact, over the last several years, more high school students report smoking marijuana than smoking cigarettes. Our lab has been conducting studies of cannabis or marijuana for more than 2 decades, as I mentioned, primarily recreational marijuana use, more recently, in addition to that, medical marijuana use, but it's not always easy or straightforward. So what are some of the common obstacles we often see? Well, first of all, when we think about adolescents or emerging adults, are they accurate historians? Do they have difficulty, one, recalling what they've done and how they've done it? And do they have an adequate knowledge of substances? Very often we have kids say, I used this thing, it looked like this, it felt like that, it smelled like this, but they have no idea what they used. Honesty. Honesty comes into play when we're thinking about social status. Very often teens do not want to risk losing face or status among their peers. It's also difficult sometimes for them to trust adults. Parental permission or knowledge is also a real consideration. If I tell you this, will you tell my parents? Will they get to know about this? Changing drug trends and new products. Very, very important. Again, I'm using marijuana as an example because it happens to be my area of research. But for example, within marijuana research, we have new products and new modes of use emerging now that we had never heard about, between 7 and 8 years ago. Stamina for completing studies. Some studies are incredibly comprehensive and a bit labor-intensive. Can they actually withstand all of the study procedures? And finally, what about their willingness to commit to a research study? So all of these things are fairly common obstacles when working with adolescents or emerging adults. So how do you do this? One more poll question. Have you ever worried about participants being forthcoming or honest regarding their substance use? Yes or no? Go ahead and use the screen and post your answers. It looks to me as if an overwhelming majority, a little over 88% of you say yes, and a little under 12% of you say no. So you are worried about participants being forthcoming and honest, and we'll talk about strategies to improve the likelihood that subjects feel comfortable telling you exactly what they're doing and, importantly, how they're doing it. So I mentioned, again, we'll talk about these methods in the backdrop of actual research in terms of, in this case, marijuana. So the study aim of these studies, or some of these data that I'll present to you, was basically to examine the potential impact of the age of onset of marijuana use on both performance of neurocognitive tasks and measures of brain structure and function in chronic heavy marijuana smokers. Our hypotheses were simple. Basically, we hypothesized that individuals with early marijuana onset, and we defined that as regular marijuana use prior to age 16, would be associated with worse performance on tasks relative to those who began using marijuana later, after age 16. We also hypothesized that we would see altered patterns of brain activation during tasks requiring frontal or executive function, and altered patterns of brain structure relative to those with later onset. So where do we start? Well, the first issues really have to do with study design and enrollment. Defining study groups is a significant consideration. You have different choices here. You can assess substance use by examining discrete groups, for example. In this case, we were looking at early versus late onset, which allows us to look at the potential developmental effects of marijuana use. You can also look at things like casual versus chronic use. This allows you to look at the effects of frequency or magnitude of marijuana use, and later I'll underscore the importance of assessing all of these things together. You can look at current users versus those who have been abstinent to distinguish the differences between acute or residual effects of marijuana use. Or you can assess substance use along a continuum. And people do lots of different things depending on their study design. In this particular set of studies, we were interested, as I mentioned, in those with early versus later marijuana use onset with regard to the smokers, and we also studied a group of healthy controls. Also important to consider enrollment criteria. It's very, very important to be stringent and highly selective, but to be realistic. So some of the areas that have caused some problems for investigators over the years include issues of comorbidity, evaluation of physical health status, substance use criteria, cognitive testing, and neuroimaging considerations. So these are some of the issues that come up when you're determining enrollment criteria. So first, let's take comorbidity. So when we think about Axis I pathology, it's important to consider whether you would exclude other Axis I pathology relative to what your particular area of study is. You want to assess for both past/lifetime versus current pathology. It's very, very important to not only assess for current pathology, but past or lifetime. and assess groups with the same instruments. So for example, here I have indicated the SCID-P versus the SCID-NP. We choose to use things like the SCID-P for all of our subject groups because, frankly, you can't get answers to questions you don't ask. So if you use the non-patient version of different clinical interviews, when patients or subjects don't give you particularly elaborate answers, it's more difficult for novice or beginning or less experienced interviewers to sort of understand how to go. If you have the SCID-P, it gives you a little bit more latitude in terms of being able to elicit that information. Plus, you can then directly compare. If you go item by item, you actually have a direct comparison. History of psychotropic medication stimulants. It's important to consider the length of time individuals have been medicated. Also, the indications for use. Were they prescribed? Or was it more a thing of, well, a friend gave it to me? We see this very often in adolescent samples with regard to things like psychostimulants, so Strattera, Adderall, etc. Time since last use of medication. So it's important to know how soon or how recently they've used this medication. Was it many years ago? Was it just yesterday? Assessment of current clinical state is also critical. So this goes without saying for things like the structured clinical interview. It's really important to make sure that your study groups are really comprised of the individuals that you have defined as your study groups. I can't stress that enough. So you want a really thorough, comprehensive clinical interview. And of course, self-report scales in addition to clinician-administered scales. So you really want a balance of measures that individuals are answering on their own as well as clinician-driven scales. Poll question 4. In your studies of substance users, do you exclude those with Axis 1 pathology? Yes, sometimes, depending on the disorder, or no. Key in your response now. So a more even split here. A little, just under 54% of you say sometimes, depending on the disorder, and about 46% of you say no. None of you said yes. So that's actually very interesting. And again, these answers differ depending on what your study questions are. But it's important to be thinking about this because the presence of comorbid Axis 1 pathologies may in fact make it a little bit more difficult to address some of the questions you're asking. So let's move to physical health. When we think of potential areas of concern, we want to query about head injuries, losses of consciousness. For example, some people will have a head injury but no LOC or loss of consciousness. Some groups will absolutely exclude on the basis of any loss of consciousness. Other groups say if it was longer than 2 minutes, 4 minutes, 5 minutes. It's important to know what your criteria should be and to stick to it. Symptoms and sequelae. So did the individual report dizziness, double vision, nausea, vomiting, headaches, anything like that after the injury was sustained? Or did they get knocked in the head, have a headache, and the next day they were perfectly fine? Medical illnesses or conditions. Some considerations here are things that may in fact impact neuroimaging measures. So if you're doing imaging studies, you want to be mindful of medical conditions that will affect blood flow, blood cell counts, white matter integrity measures. You also want to consider specific medical illnesses or conditions that could impact cognitive performance and perhaps exclude individuals from being considered amongst part of the rest of the group. For example, illness or exclusion examples are neurologic illnesses, for example, multiple sclerosis, demyelinating disorders. Some have excluded based on HIV positive status. Chronic anemia or blood-based disorders is a very, very common one with regard to imaging studies because, in fact, if you're doing fMRI studies, which are dependent on blood oxygen level dependent measures or bold imaging, that's going to change things. And past chemotherapy. These are just some examples. It's impossible to list everything. But my point here is to consider medical illnesses or conditions in terms of whether or not you'll include them. Substance use criteria, obviously critically important. Will you study discrete subject groups versus studying along a continuum? Variables to consider here, as I've mentioned, are age of onset, frequency and magnitude of use of whatever substance or substances you're looking at, length of abstinence. Categorization of groups. What will your limits be for heavy or chronic use versus light and casual use? This is a particularly important issue because in the literature, we very rarely see a priori well-defined categories for things like light or casual use. For example, in marijuana studies, you can see studies of light or casual users who report their subjects use an average of once or twice a month, and you see other studies where the word light or casual is in the title, and they report using 4 times a week. So there really needs to be a very clear distinction. Differentiate by frequency and or magnitude. Will you have a distinction? Will it matter if they use more often or in higher amounts? DSM considerations. Remember that frequency of use does not equal dependence, although now that we have DSM-5 criteria, abuse and dependence are no longer distinguished. We just have use disorders. My point here is that frequency or magnitude of use by itself doesn't necessarily create the presence of the disorder. Alcohol use, and many of you, I think, who are on this webinar are quite facile at this. Very, very important to chart total number of drinks per week. That's current versus period of heaviest use. Remember, you want to query for current, so the last week, the last month, the last 3 months, the last year, lifetime. You want to assess for binge drinking. Be clear on the criteria. 4 drinks over 2 hours for women, 5 for men. Have the subjects reported histories of blackouts or brownouts. You want to assess nicotine use. Even if you're not particularly interested in reporting nicotine, a reviewer will ask you at some point, what was nicotine use amongst your groups, because we've seen clear differences in groups with and without nicotine use. There's lots of ways to do it. Most commonly, you see measures like the Fagerstrom test of nicotine dependence, FTND, and other tools. Remember also to query about e-cigarettes. E-cigarettes are now more common than conventional cigarettes among teens. Remember to chart mode, frequency, and magnitude of use, current versus past. Use of other substances. It's important before your studies begin to establish a maximum number of exposures for study inclusion. For example, for illicit substances, will you allow somebody who has a remote history of cocaine use but only used up to 5 times, or will 55 times be okay? Will you allow any IV substance use like heroin, or will you automatically exclude? It's important to have these well-defined and actually stick to them during the study. It's important also to include newer trending drugs like spice, bath salts, over-the-counter cough medicines like robotripping. Very, very important given what the national trends are dictating. Cognitive testing considerations. So when we think about neurocognitive assessments, it's important to query about learning disabilities, or IEPs. Was your subject perhaps part of did they have an IEP while in school? Did they ever have a documented or charted learning disability? Is English their native language? We require, for example, individuals to be fluent prior to age 7. Color blindness. Color blindness, of course, will exclude certain subjects from performing certain tasks like the Stroop color word test. You want to remember to align the age range of instruments with the age range of your participants. So, children are not just little adults, and children and adult versions of cognitive tasks are often very different. And they really are different for good reason. And I've had lots of colleagues say to me, well, we'll just use the adult version and cut it off halfway through. You don't really want to do that for a lot of good reasons. You really want a specific child version. So just make sure you find the version that really meets the age range of your subjects. You also want to make sure that your participant, that you haven't exceeded your participant's ability to sustain attention throughout the testing battery. For children and adolescents and even up to emerging adults, an 8 or 9 hour testing day really should be broken up with many, many breaks, snacks, etc. You also want to ensure subjects are not acutely intoxicated during the assessment. This sounds like absolutely common knowledge, but I've had a lot of people say, these people look at me with glazed eyes and they were slurring. I'm not sure what the problem was. Well, I think we know what the problem was. It's important to use a breathalyzer or saliva quick test. And of course, don't forget to use your eyes, your ears, and your nose. When thinking about neuroimaging contraindications, the most obvious things that jump out are things in this particular group like dental devices, braces, metal posts, non-removable retainers. These are all incredibly difficult to get past with regard to imaging. Implanted devices are not nearly as common in our children and adolescent samples, but they do exist, so you want to ask about pacemakers, shunts, etc. Pregnancy, of course, is an issue. Non-removable piercings or dermal piercings, and of course, claustrophobia, anxiety, or being unable to sit still for the scan duration. There's a lot of different neuroimaging contraindications, and again, every site is going to have their own list. It's important to be mindful of the list and to not take for granted that given the subject's age, they won't have any of these, because in fact, kids often do. Very, very important, again, every one of you has your own IRB, but just to make sure that even if they've been queried, you re-query before these kids or teens enter the scanning environment. That's my plug as our MR safety officer for my department. I always like to make sure people are remembering to be safe. So in terms of subject recruitment, we have a poll question. Do you utilize online sources for recruiting, for example, social media, Craigslist, or job boards? Do you use multiple online sources, social media, or nothing at all? Key in your response. Different IRBs, again, across the country will have different rules and regulations about this. So in some cases, I've heard of some sites being unable to utilize social media. And it looks like the majority of you, 56% or so, use multiple online sources or nothing. So no one's using only social media, which I would actually maintain is a great approach. Multiple online sources really tend to capture a much more heterogeneous sample than simply using social media. For those of you who don't, maybe we can get into this in the Q&A. I'd be curious as to why, only because it seems to really have changed the way that we're able to recruit given the pervasiveness of social media. So moving ahead to issues of subject recruitment, where do you get subjects? Different sites have different requirements, again, and different areas that they're allowed to advertise in. Some common spots are community bulletin boards, coffee shops, gyms, local stores, recreation centers, college campuses, online radio, Pandora, Spotify ads, social media, or Craigslist, although I have that lovely yellow circle with the strike across it because, in fact, I have found personally that Craigslist is not a particularly reliable recruitment source, although I had a collaborator who insisted, and we disqualified almost 80% of subjects who responded through Craigslist ads. So for whatever reason, it's not a great one. Phone screens. So this is my, I think, my pitch for having the most comprehensive, although not overwhelming, phone screen that you can, because it really does lead to lower rates of disqualification. In addition to collecting basic contact information, this is the time where you want to really start collecting things like brief psychiatric history. Specific questions are critical here, and it's not to overwhelm your subject or to potentially alienate subjects. You don't want to be too in their face, but you do want to potentially exclude individuals who clearly will not meet your criteria. So, for example, if someone's been hospitalized repeatedly for major depressive episodes and that's an exclusion, you wouldn't bring that person in. Medical history. You want to talk about illnesses, potential MR contraindications, head injuries or losses of consciousness, and of course medication history. And when we get to this point in medication history, I also always like to underscore the important point of not asking about use by drug class. There are lots of people who take substances or medications without knowing the actual indication. I've had lots of people say, oh yeah, I take trazodone, but that's for sleep. They have no idea that it fits into an antidepressant category. And of course, substance and alcohol use. It's important to collect this information during the phone screen because you can actually corroborate the phone screen information with information that you get actually in person. So you can revisit that when they come in if you've approved them to move forward. So I can't stress enough, a really good phone screen really does cut down on the potential disqualification once individuals are at your site. So assessment considerations with regard to substance use. This is really sort of the meat and potatoes of assessing substance use in the population. So for example, in our studies, we're very interested in assessing the age of onset of, for example, marijuana use. So we start with questions like this. Tell me about the first time you ever used marijuana. We don't actually say smoked anymore. Tell me the first time you ever used it. Who were you with? How old were you? Where were you? What grade were you in? Was it before or after your birthday of that year? How did you use it? Do you remember how much you used? What you're really doing is getting a narrative and asking for details about subjects' first use because it helps them better remember their experiences. And I can tell you that it is alarming how much detail we get from subjects about their first ever experience. It's like other first ever experiences, I think, in their life, and they remember with tremendous clarity. So it's a good way to go. And once you've established the answers to these questions and sort of taken them back, if you will, we go ahead and ask about age of onset of regular use by asking related questions. So tell me, when was the next time you used it? Who were you with? How did you use it? When did you begin using, in this case, marijuana more regularly? But remember, for whatever your substance you're interested in assessing, all of these things can be amended. How often and how much were you using? It's important to establish the criteria for, quote, regular use if that's an important part of your study. Determine, again, a priori, what you mean by regular. Is it once a week, once a month? How did you use it? Determine frequency of use in between first use and their report of first regular use, because what you really want is a comprehensive record of substance use. You can answer all sorts of questions when you actually have this narrative, and even though you're going to pick discrete pieces of these parts of information and put them in your database, it's great to have the data to go back to and mine for other aspects should they come of interest later. So when we think of assessing frequency and magnitude of use, there are many different ways to do it. Using something like the timeline follow-back procedure has been very, very helpful for many groups, including what looks like many of the participants who are on this webinar. It's the most widely employed standardized measure that assesses retrospective self-report estimates of substance use. It was first developed for alcohol use, but it's been modified for use for many other substances. And you basically provide subjects with a calendar, and you use important dates as anchors to facilitate memory. And in conjunction with that clinician-driven interview style that I just mentioned, who were you with, how were you doing it, you really can get very, very specific information about first use, heaviest use, etc. Here's an example of one of our respondents in terms of marijuana use, and this is just use within the last 7 days. And again, different groups will ask different questions. Use within the last week, the last month, the last 3 months, the last 6 months, a year. You can break this down however you'd like to do, and of course contrast that with lifetime use. But here what we see is in this modified TLFB, we have information about frequency, magnitude, mode, and type or products used. And if you can see on the right side of the screen, the far right where it says daily totals, all of this information, let me just see if I can actually highlight this. Yes, I think you can see this. So here this tells us yesterday, 2 days ago, 3 days, etc. I'm getting help from my moderator, I see. The specific day of the week, because it's always important to write that down. Don't assume you're going to remember when you saw them, even though all of your pages should be dated. You're going to ask them exactly how much they used as best they can remember in terms of grams or however you're measuring the substance, how they used it, was it a joint, a spliff, a bowl, with how many other people, etc., to calculate the daily total column. That daily total column allows us, for example, to calculate total number of grams used this week and total number of episodes this week. And was it shared? Was it used alone, etc.? In addition, you have lifetime use estimates based on the skid. What if you get someone who says, like poor Steve Martin here, I have no idea how much I smoke? Well, there are other questions you can ask. For example, in the case of marijuana, how much do you or your friends buy, and how long does it take you to go through it? You can calculate that in ounces or grams, preferably not dollars, but that's helpful if you don't have anything else. How long does it take you to go through it? How many people did you share it amongst? Was it equal, or did your boyfriend have 2/3 of it and you had 1/3? You want to compare estimates of weekly, daily, and or monthly use and ask questions when the numbers don't add up. We have lots of folks who are pretty sure they're using this much, and then they tell us how much they're buying in a week. We do the simple math, and they say, oh, wait a minute, hold on, and they correct themselves. And I'm also a big fan of visual aids. So in my lab, we have lots of different mechanisms to assess use. One of them is a visual aid chart, something like this, that shows individuals how big, for example, on the left side of the screen, some of the more standard size bowls are in a pipe, in terms of how much marijuana would fit in each of those bowls. And then on the right side, you can see that what you have is a half gram or a gram or an eighth of an ounce of marijuana just visually depicted, and they can kind of guesstimate. At the bottom, you can also see images of things like shatter. These are concentrate products. So it's important to have some visual aids if, in fact, you have individuals who don't have the greatest ability to be able to tell you how much they're using. Some people say, I don't worry about that because I go ahead and pull urine. And so I'll know how much they're using if, in fact, I collect urine. Attempts to correlate urine concentration with impairment or time of dose are complicated by a number of variations in metabolism, metabolite accumulation in chronic users versus those who are more novel users, urine volume changes due to diet, exercise, age, all sorts of other factors. So a positive result based on only your urine cannabinoid test indicates only the likelihood of prior use. It's just a yay or nay. Did they use it or didn't they? It doesn't really tell you much about how much they used. In terms of sending urine out for assessment, we tend to suggest people use a THC over creatinine ratio, although at our most recent CPDD conference, we heard that may not be the very, very best measure, although it is still one that's widely used. looking at THC over creatinine helps to control for metabolism effects, but it doesn't provide information regarding frequency of use. So it's very important that the information you collect from your subjects via, again, that face-to-face assessment regarding frequency and magnitude of use is more accurate than just depending on your urine screen. THC urinalysis is useful supplementary information. Novel products and lingo. It's very, very important to stay current. Not only will it buy you a little bit more credibility with your study subjects, it really does help you understand their patterns of use. So we're all pretty familiar these days, those of us who deal with subjects who are maybe not even using marijuana exclusively, but who use marijuana at all, with regard to edibles versus smoked flower. Some of you may be less familiar with what we call concentrate products. These are products like butane hash oil or hash dabs. Probably heard the terms wax, shatter, butter. These are all concentrate products with THC levels. That's the active psychoactive component of marijuana. Levels tend to range from 40% up to about 85% THC in concentrates. Oils or tinctures. People used to use marijuana in only a few ways, typically. Joints or bowls or bongs. Now we have blunts, we have spliffs where you mix marijuana with tobacco. Instead of smoking it, you can vape it or use a vaporizer. You can use a dab rig. You can use a bong or a bubbler. You can have a pipe, a bowl, a dugout, a one-hitter. All of these things should be familiar to you because you want to be familiar enough with the terms when they are reported by your subjects to understand what they correspond to. Marijuana potency has continued to increase over the last 2 decades. National averages these days are about 12%, according to a paper that came out just this year. I can tell you that there's lots of ways to estimate potency. The most cost-effective, actually free way of doing it is to ask your subjects. So, with regard to your product, do you think it's high, medium, or low THC potency? By the way, what's the name of the strain? People are usually very proud to tell you what they're using, where they got it, etc. You'll get more information than you may want. You can also send it out for laboratory analysis if you happen to be in a state where you can have that done, and not everybody is. Laboratory analyses will give you actual THC potency and constituent analysis, for example, THC over or ratio of THC to cannabidiol or CBD, the main non-psychoactive component in marijuana. This is a much more objective and detailed assessment, and I would recommend that study staff or PIs don't put themselves in a position, unless you have a Schedule I substance license, to actually be in contact with the substances. You want to have your subjects deal directly with an outside lab. This is just an example of a laboratory report from one of my studies where we actually do collect samples from individuals. So you can see that you really do get very detailed information about what products individuals are using. This may or may not be of interest to people. So again, against the backdrop of some ongoing research, with regard to our ability to look at discrete groups, in this particular set of data that I'll show you just a little bit of, we have a group of 50 chronic heavy marijuana smokers. That is, they report use 4 or 5 of the last 7 days. They have a lifetime minimum exposure to marijuana of at least 2,000 times. They are also free of other Axis I pathologies, that is, all other Axis I pathologies. By way of comparison, their healthy control samples, there's 34 of them in this sample, do not have any Axis I pathologies, including marijuana use disorders or related disorders. I should say the MJ smoker or MJ user group, some of them, of course, do meet criteria for marijuana use disorders. Neither group may use other illicit substances more than 10 times in their lives. And you can see with this, in this table that the controls in smokers are well matched for age, IQ, days of alcohol use within the last month, and use of nicotine. When we take the marijuana smokers and break them into our discrete groups, as I mentioned earlier on, we wound up with 24 with early onset, that is, regular marijuana use prior to age 16. 26 had regular marijuana use after age 16. And other than that, they were still well matched with regard to IQ, days of alcohol use, and nicotine. The first thing that emerged when we began to look at the groups, because we would split them into discrete groups, we could do this. Average number of smokes per week was about 24.5 for the early onset group and about 13.5 for the late onset group, which was statistically significant. Also, grams used per week. And remember, we get that by asking exactly how much they're using, with whom, show us, etc. 14.5 grams on average for the early onset group, 5.6 for the late onset group. Also statistically significant. No difference in duration of marijuana use. So here are the take-home messages. Compared to those who started smoking regularly after age 16, those with early onset of marijuana use smoked twice as often and over 2.5 times as much marijuana per week as their later smoking counterparts. So let's talk a little bit about cognitive testing and some considerations here. So, adherence to abstinence, and every group will have a different requirement in terms of how long an abstinence period they require. Some groups require 14 days, some groups require 24 or 12 hours. It's important to ask, when was the last time you used X, the substance, for example, in this case, marijuana? We have found it's very helpful to say something like, we're going to collect some urine, so it's great if you could just tell us when the last use was. Subjects often believe that from your urine screen that you're going to do an in-house triage with and then send out for quantification, you will be able to tell how many hours it's been since they used, and it's a remarkable mechanism to elicit honest responses. We just hold up an empty urine cup and I say, so tell me, really, truly, when was the last time you used? And we get a lot of honesty that way. Again, as I alluded to earlier, like poor Seth Rogen here, you want to use your clinical judgment. Glassy eyes, a strong odor, for example, of marijuana, in the case of marijuana studies, inappropriate behavior, trying to eat the desk. These are all signs that your subjects may, in fact, be intoxicated. Really important that you reschedule those subjects. When we think about other considerations, we always think about IQ. It's important to ensure that any potential cognitive differences that you note between your study groups are not simply a result of baseline differences in IQ. Therefore, it's important to assess IQ. I've had a lot of people say, well, we don't really care about overall IQ. It's really important also to be able to determine whether or not the substance use is impacting IQ, and we've seen some of that in the literature more recently, or questions about that. Commonly used IQ measures are again, sort of these full-scale measures like the WAIS or the WISC. More common are the abbreviated IQ measures like the WASI. The WASI comes in 2 flavors, the 4-factor, which gives you a full-scale IQ estimate as well as verbal and performance IQ estimates, or the 2-factor, which just gives you a full scale. Other groups use things like the NART or other measures. It's important to remember that reading is not necessarily equivalent to IQ, and it does come with a little bit of a cultural bias, so we always try to encourage people to use things like the WASI. It's important when you're selecting cognitive measures to be included in your battery to consult with someone who has neuropsychological expertise. From the looks of the folks who are on this webinar, I have no doubt that you have those folks on your staff. Consider training necessary for staff to administer the battery, not just reading or giving them the manual to read and then sending them off on their own. Assessing a single domain versus a range of domains, and of course considering the length of the battery. It's important to balance that, looking at multiple domains versus how much fatigue the participant may have to endure. In the studies that we're doing currently, one particular focus has been on assessing measures of cognitive or executive function. Of course, these are controlled by the frontal part of the brain. They involve things like monitoring and changing behavior as needed, decision-making, abstract thinking, rule acquisition, and inhibiting inappropriate responses. Lots of different ways to do this. One measure of this is the Wisconsin card sorting task, sort of considered historically a gold standard measure of frontal executive function. Subjects are given 4 stimulus cards and a deck of cards from which they take one card at a time and are told simply to sort the card in front of one of the 4 stimulus cards. Without knowing it, the rule for sorting changes after a number of correct consecutive responses, and the idea is for them to utilize the feedback from the examiner to change their behavior. Here, what we're looking for are high numbers of categories achieved, or correct consecutive responses, and low numbers of perseverations or incorrect repetitive responses. And what we see here, if we look at data from some of these studies, the controls are in blue, the smokers are always going to be in green. What we see is that the controls achieve higher numbers of categories overall than the smokers, and significantly fewer perseverative errors. So you can see, I'm not sure if you can see this arrow, but total number of categories significantly different between smokers and controls, total number of perseverations significantly different. But when we go ahead and look at smokers broken into early and late onset, now the early onset group is light green, the late onset group is dark green. The between group differences that we saw are almost exclusively attributed to the early onset group. This is true across the board in a number of frontal executive measures. I'm just using the Wisconsin as an example here. But here what we see, again, if you look at the category total, that's that third column from the left where it says total. Late onset group gets 9 categories versus early 7.7. Early onset group makes significantly more perseverative errors at almost 14.2 versus 6.4. So significantly lower performance in the early onset group. When we think about neuroimaging considerations, it's very important to remember that for any neuroimaging study, structural imaging is required, typically to rule out clinical findings like tumors, aneurysms, or degenerative disorders, and it's going to be necessary to have those structural images for fMRI or DTI analyses. Some groups say they don't necessarily bother with it. At my site, it's mandatory to ensure everybody has had a clinical read by a neuroradiologist. When we think about measures that we do inside the scanner, they vary widely depending on your question, but sticking here with the frontal executive questions that we were asking, we took a Stroop color word test and amended it for use inside of the scanning environment. Subjects do one of the 3 conditions, color naming, word reading, or interference, during one of the 3 scan epochs that we do for the Stroop color word test. What we see when we look at performance is similar, again, to the Wisconsin card sort. Here again, controls are blue, smokers are in green. Significantly lower performance in the smokers with regard to accuracy relative to controls. Higher errors of omission and commission in our smokers relative to our controls. And when we split the groups, that difference becomes very clear with regard to who's driving that difference. Again, the early onset group is in green, significantly lower accuracy relative to both controls and this time late onset smokers. Same is true for errors of omission, which are significantly higher in the early onset group, and errors of commission. Errors of commission are directly related to a failure to inhibit inappropriate responses. When we look at patterns of activation, again, here's our lovely, very clearly defined groups, and we see different patterns of activation exhibited. And if anybody's interested, we can talk about this in the Q&A. This is a cingulate mask that's been applied using SPM 8. And here what we see are different patterns of activation. This is actually a contrast for the interference condition minus the color naming condition. Different pattern of activation in the controls and smokers, but when we split the smokers into early and late, that difference becomes even more striking, with the late onset group exhibiting a slightly more similar pattern to controls with the more posterior area activated than the early onset group. So this is important to consider. White matter in DTI, some of you do diffusion tensor imaging. It's important to keep all these considerations in mind. Remember that white matter is thought of as the brain subway system, connecting brain regions for fast, efficient communication. DTI is a technique that allows us to look at organization and coherence of white matter within the brain. And I'll just show you, see these little trains are moving. They sort of depict white matter. There's different measures that you can get from studies of DTI. One of the primary ones is called fractional anisotropy, or FA. It's basically a measure of white matter organization or coherence. What you want here are the numbers to be high. They range from 0 to 1. High numbers are better or more organized. And more organized tissue here, or white matter, is equivalent to better communication in the brain. And when we look at basically an FA skeleton, this is generated on a T image. What we see here are the green is the white matter, that's the map, and the areas in yellow designate differences, statistically significant differences between the smokers and controls. So just taking up at the very top that smile area, the left and right genu of the corpus callosum, the largest white matter structure in your brain, looks significantly different between smokers and controls. But in what direction? Once again, blue is the controls. Early smokers are in light green, late smokers are in dark green. Significantly lower white matter integrity in the left genu of the corpus in the early onset group compared to the controls, as well as in the right genu. So again, a statistically significant difference in early onset smokers relative to the controls here. And in fact, when we look at the relationship between age of onset of use and white matter, we see a relationship. The earlier the age of onset of use, the lower the white matter organization. That's true in the genu of the corpus callosum and in other areas as well. So in this case, we're using age of onset, we're regressing the data. So it's important, again, to think of how you're going to use the data when you begin to collect it. This is a very, very important finding. So to summarize some common pitfalls, poor participant screening. You get higher disqualification rates, which are equivalent to lost time and money in your studies. Don't just ask about substance use, go ahead and use drug tests. People are ever fearful of that little urine cup that you're going to use. Overly restrictive inclusion criteria will not represent the general population and may yield low recruitment. Failing to consider all study contraindications, for example, not controlling for comorbidity, you may not be able to disentangle the effects of substance use versus other existing pathologies. Neuroimaging or cognitive testing contraindications are also important to consider before you begin those subjects in your study. Substance use assessment doesn't match study aims or isn't rigorous. That's the other big issue to watch out for. I think it's not really a question of not always matching study aims, but making sure you're asking the questions you need answers to address the issues raised in your study. So, keys to success. How do we do this? Comprehensive participant screening. That phone screen is your first step here. Having very clear inclusion and exclusion criteria, for example, regarding physical health, cognitive testing requirements, and neuroimaging potential contraindications. Thorough substance use assessments that address variables of interest and reflect your hypotheses, for example, in this case, age of onset, frequency and magnitude of use, mode of use. Collaboration with others with expertise in specific areas, for example, neuropsychologists or scientists with neuroimaging expertise or statisticians, will ensure that you are conducting studies that are designed to answer the questions you have so thoughtfully raised in your applications. And with that, I would close and thank you for your time and take any questions you might have.
Well, thank you, Staci. I think that your coverage of this, the methodology involved in incorporating substance use issues in the clinic and as well as in our studies of research is very thorough. So we're going to put the recording of this session on our CTN Dissemination Library's website, where individuals will have an opportunity to review it again. And if you have any questions after looking at it again or sharing it with your colleagues, we encourage you to do that and reach out to us at CTN Training, here ctntraining@ms.com, and we'll get those questions over to Dr. Gruber. And if we can even have a follow-up discussion and have enough interest in that, we will do that as well. So thank you, Staci, for coming to speak to us today.
It's a pleasure. Thanks so much. And if anybody has any questions, please let me know.
Great. So we'd like to invite everyone back next month on August 10th, where will be Dr. Gray, Kevin Gray of the Clinical Trials Network will discuss pharmacotherapy trials for adolescent substance use disorders from concept to execution. So an invitation will go out for everyone to that as well, okay? And that will end our session today. Thank you for coming.